All right, can you guys all see my screen?
Yes.
Yes.
Fabulous. Okay, awesome. Well, thanks again for hopping on. It sounds like IRB is just around the corner, and we're just waiting on some subcontract stuff. So I still anticipate it might be a month before you guys get up and running officially, but I figured this way you have some time to take a look at the training here, absorb some information, have a chance then to kind of look back at the MOOC or anything and kind of ask any questions. Some sites also find that it's helpful to start kind of like screening in advance, like a week or two in advance, not to enroll anybody or to track, but just to start getting a feel for the patient population and what questions might come up. So we'll try to run through this as fast as we can. Hopefully it won't take the full hour and a half, but we'll see how it goes. All right, so our primary objective for this study is to derive and validate thresholds of TNF-alpha below which kids with MODS are at an increased risk for either death, prolonged organ failure, or nosocomial infection. And our primary analyses, we are trying to identify the optimal thresholds of immune function for use in future trials. And we're also trying to identify risk factors of immunoparalysis. So that could either be disease-related factors, treatment, or host-related factors. Our inclusion for the study are, they have to be admitted to the PICU or the CTICU. And remind me, do you guys have a separate CTICU or is it all in one?
It's one mixed unit.
One mixed unit, okay. So yeah, so you can enroll both populations. Kids do have to be at least 40 weeks gestational age and less than 18 years at the time of consent. And for patients that have had chemo or radiation in the month prior to enrollment, they have to have demonstrated a white blood cell count of at least 1,000 in the 24 hours prior to enrollment. So let's say you have a kid that you're planning to approach, they had chemo 2 weeks ago. If they had chemo 2 weeks ago and didn't have a white blood cell count done in the last 24 hours, you couldn't even enroll them. And honestly, likely that patient, their white blood cell count would be too low anyway. But if they did have chemo or radiation and the white blood cell count in the last 24 hours was at least 1,000, then you'd still be fine to proceed with enrolling. And then of course they have to have the onset of at least 2 new organ dysfunctions as measured by our approved criteria, which I'll show you soon, in the last 3 days. And you also have to be able to obtain the first blood sample in the first 3 days of MODS. That is not a 72-hour window. Sometimes people get confused. It is a 3-day window. And I have a slide that helps to kind of visualize that in a minute. Exclusion criteria would be limitation of care orders, a strong clinical suspicion of or ongoing evaluation for brain death, and previous enrollment in the study. So this is just kind of a highlight of what our PRU worksheet looks like. So we do have like a paper CRF. You don't have to use the paper CRF, but this worksheet is part of that CRF packet. It's like the first kind of main page. It's something that I recommend that people maybe print a handful and have at your desk as you're screening, because as you're looking at a patient, it does have like all the different criteria by organ system, and then you can kind of make notes and that sort of thing. So that is for your use to help as you're screening. Certainly you can use some other kind of log or something, but. Okay, so when we're talking about determining when a patient meets criteria for MODS, so that is the time that they develop 2 or more organ dysfunctions. So, and we'll go through the systems themselves later, but let's say, for example, they meet respiratory dysfunction criteria at 5 a.m., and then cardiac dysfunction criteria at 10 a.m., and then renal dysfunction criteria at 9 p.m. Well, your MODS onset time is always going to be the second onset. time. So this is something that trips people up. Sometimes if there are 3 or 4 organ dysfunctions, they pick kind of the last one in the cluster group. But your MODS onset time will always be the onset of organ number 2. Similarly, even if respiratory dysfunction onset, if that was 2 days prior to that cardiac dysfunction onset, that's fine. We don't care. There might be times that there's a larger window like that. You'll still just use that that second organ onset time. The reason that this is important is that everything for the study is based on that MODS onset time, which you'll see. And then similarly, so this is another example I gave where respiratory onset is on, like January 1st, and then cardiac is like 9 days later. Like I said, it's still going to be that second organ onset. So in terms of your kind of activity timeline for consent and enrollment and blood sampling. So as I mentioned, it is a 3-day window and not a 72-hour window. So if your MODS onset is on day 1, it can be anywhere. It could be 10 a.m. or it could be 10 p.m. We're still using a calendar day. So your deadline for consent and the first study sample is 23:59 on calendar day 3. So if you're not even able to consent until calendar day 3, which certainly happens, you need to make sure that you're able to get the first sample. If you're consenting late on calendar day 3 and you're like, there's just no way for us to even get a sample, then probably not worth your time to even consent them and proceed, because we do have to have that sample by day 3. As a reminder as well, subjects do still have to have active MODS at the time of consent and at the time of first sample. So sometimes we find that a patient, you're screening them, they have MODS, but then by the time you go to approach for consent, let's say they have, they get either extubated or their cardio dysfunction resolve and they're down to a single organ dysfunction, you cannot proceed with consent. It has to be active at the time of consent. It does also have to be active at the time of first sample. So similarly, sometimes we will consent a patient that has MODS, and then you come back a couple of hours later to get the first study sample, and now they have single organ dysfunction, not multiple organ dysfunction. You would not proceed with getting that first study sample. So yes, we do have times where patients are consented, but then they're never sampled for the study, and therefore we also don't collect data on them. Okay, so we'll go through now. Oh yeah, go ahead.
Can I hopefully you don't mind if I interrupt and ask questions as we go?
No, not at all. Go for it.
Do you find it easier to consent prior to potentially even having MODS, so that when they do develop MODS, the blood collection's that much easier, quicker? Is that what you were getting at?
No. Yeah,
Okay.
no, and actually you cannot consent before then. That would be technically considered a protocol deviation because of how the protocol is written.
I guess I'm confused
is,
in the sense that they develop MODS, and you're saying at the time of the blood work, though, if they don't have MODS, is there the change in between? Okay.
Yeah, and so sometimes those changes just occur because, so as we go through the systems, you'll see, so our most common MODS scenario is going to be you have a patient with a breathing tube and they have, let's say, epinephrine on board. But if they're at like a really low dose of epi, we've had times where the study staff goes into consent, the patient, family, and they still have both the epi running and they're intubated. But then by the time they go back to get that first sample, the epi is off. And so now they're only intubated, so they just have single organ dysfunction. So all that we're saying is that like it's important to double check that they have MODS when you go into consent, and then also double check that they have MODS when you get that first sample, just to make sure that it's still going. It's not an issue one way or another. I mean, we know that sometimes we're going to consent a patient and then end up not sampling them. It doesn't happen very often. And we just kind of use them as we still assign them a study ID number because we've got consent, but you just won't really do anything else with them. But yeah, unfortunately, we can't consent ahead of time. Does that kind of make sense?
No, that's helpful. I guess I
Okay.
misunderstood the delay between consent and blood draws, but I guess in real life that can
Oh,
happen. Okay.
and yeah, and ideally there wouldn't be a delay. I mean, I think most of the time we consent and then get the study sample right away. I think sometimes when this comes up is because when we get a study sample, it does take 4 hours to process. It's only like 30 minutes of hands-on time, but because of the LPS stimulation, it has to incubate for 4 hours. So sometimes when we see this is when we consent, let's say on day 2 at like 4 p.m., right? So you're consenting a patient at the end of the day. You don't have time. You're not going to stay around until 8 p.m. to get that LPS off. And so sometimes they'll consent at the end of one day and then go back the next morning to get the sample. And now they have single organ. So that's probably the most common scenario when that would occur. But yeah, we do recommend get that study sample as soon after consent as possible to hopefully not run into this issue.
Right. That's exactly what I was going to say about it. And that's something that happens at CHOP sometimes, and we usually try to gauge, say, like in your example, Josie, if it's day 2 at 4 p.m., we'll try to gauge is this patient likely to persist in mods, and if they're not, then we'll just kind of wait till day 3 to check their mods again and do consent and sample at the same time. But if it's late in the day on day 2 and it looks like they will probably still be in mods by the next day, then we'll get consample and then sample 1 on day 3.
Thanks, Nick. All right, so I'm going to go through the next handful of slides that actually goes through the PRU criteria by system. I am going to slightly breeze through them, mainly because there are so many different criteria. You'll have the worksheets and it's going to take time to absorb it, but I just wanted to at least give you a brief introduction of what it looks like. So for respiratory dysfunction, for them to meet respiratory dysfunction criteria, they would have to meet at least one of the following. So a respiratory rate of greater than 90 for infants or greater than 70 for kids at least a year old, or PaO2 of less than 40 without cyanotic congenital heart disease, or PaCO2 of greater than 65, or a PF ratio less than 200, again without cyanotic congenital heart disease, or mechanical ventilation. If that's used postoperatively, it has to be at least 24 hours, which I'll explain more in just a second. For mechanical ventilation, for tracheostomy patients, they must not require mechanical ventilation at baseline, or they could meet other respiratory criteria. So if you're screening a patient with a trach, if they have a ventilator need at baseline, even if it's like only at night, then they wouldn't be able to meet that mechanical ventilation piece for respiratory dysfunction, but they could still potentially meet respiratory dysfunction criteria if, for example, they had a PF ratio of less than 200. So they could meet other criteria, they just wouldn't be able to meet the mechanical ventilation component. Now, if it's a trach patient that has only cool mist trach collar during the day or at night, and they don't use a ventilator at all at home, and then they come into your unit and now they need a ventilator, then they could meet criteria. For mechanical ventilation, we are including non-invasive ventilation, which does also include high flow of at least 6 liters per minute. And it does include VV ECMO. So for that post-op ventilation, where it says it has to be for at least 24 hours post-op. So let's say they're in the OR, if they're intubated for the surgery only, they weren't intubated prior to surgery. So they're intubated for surgery, and then they come back to your ICU, you have to wait 24 hours before that respiratory onset starts. We don't want patients that are, going to get extubated soon after surgery. So that's kind of why we have this one in place. So you're calculating that respiratory onset time at the 24-hour mark after coming back to the ICU.
Can I
For
ask?
cardio,
respiratory
yes,
rate
please.
is so for example, the gases or the respiratory rate, are those numbers the highest in that, in that day, or the most recent? Say, if you have a bronchiolitic that's
Hmm.
breathing 90, put them on high flow and now they're breathing 60. Is
Yeah.
that mods now
Um,
improved and not qualify?
yeah. So there are kind of two different scenarios with that. So if there is for vital signs, we will typically say it's fine to use the highest, like it's the highest within like the last 24 hours, basically. So if their respiratory rate was 100 and then now it's 60, because now they've got some support or whatever, you could still count that respiratory rate, that tachypnea, as long as it was within the last 24 hours. For labs, we would take the most recent only, and I only say that because if there is a lab that shows a clear resolution of a criteria of an organ dysfunction, then that's basically showing us like a resolution, and so we wouldn't want to enroll them, if that makes sense.
Sure.
Okay.
Thank you.
Mm-hmm. And I do go over that a little bit in a couple of slides, so hopefully it will perhaps make a little more sense. So for cardio dysfunction, they'd have to have one of the following: systolic of less than 40 for infants or less than 50 for kids at least a year old, or heart rate less than 50 or greater than 220 for infants, or less than 40 or greater than 200 for kids at least a year old, cardiac arrest, or a pH of less than 7.2 with a normal PaCO2, or continuous vasoactive drug infusion for hemodynamic support. So that excludes dopamine of less than or equal to 5 mics per kilo per minute. So I will say most patients meet cardio criteria based on the vasoactive drug infusion. And just to clarify, this is not counting like nicardipine or nipride. These are things we're looking at for support, so like epi, norepi, phenylephrine, and those kinds of things. And the dopamine exclusion is for, I can't remember, but less than or equal to 5 mics per kilo per minute. But for vasopressin, that's where this also comes in, where we're saying it has to be for hemodynamic support. The vasopressin might be used at a certain kind of dosage range for diabetes insipidus, and a different dosing range for hemodynamic support. So if they're using the vasopressin for diabetes insipidus, so we would not count that for cardiovascular dysfunction. VA ECMO also counts. And as a note, if they're on VA ECMO, they automatically qualify for cardio dysfunction and respiratory dysfunction, regardless of, if they're a trach vent patient that they require mechanical ventilation at baseline, that's fine. If they're on VA ECMO, they just automatically qualify for both. So as far as the cardiac arrest goes, the cardiac arrest qualifies only for the calendar day of the the arrest event. So if they arrest at 1 a.m. and then they get intubated, then that arrest would qualify them to enroll and sample on that day, on the 1st. But if you're screening in the morning and you see that they arrested yesterday at 10 p.m., you would only be able to enroll and sample them if they still meet other cardio dysfunction criteria. So the reason, again, that we have this in here is sometimes we get kids that have a really brief arrest event, and the next day they're extubated and they seem normal and they're getting ready to go out of the ICU. We don't really want those kids. We want the kids that have a true MODS, that are really kind of the sickest of the sick in your ICU. If they had a cardiac arrest event that was really kind of more impactful on their cardiovascular system, then they're probably going to be on some kind of a vasoactive drip after that event. So that's why we say it's fine to enroll them on the day of the event, but if it's the next day, they really should be meeting other criteria for us to consider enrolling them. Any questions on cardiac? Okay. To meet heme dysfunction, they'd have to have a hemoglobin of less than 5, or white blood cell count of less than 3, or a platelet count of less than 20, or DIC. And we would call that, say that they have DIC if their PT is greater than 20 or the PTT is greater than 60. And that would be in the absence of any anticoagulation therapy. And sometimes we have had people misunderstand the anticoagulation in terms, sometimes our IV fluids have like a little bit of heparin in them that's really for line patency and not like a true like systemic anticoagulation. So we're just saying, for like a true systemic anticoagulation therapy, that's when we would negate the PT, PTT values for qualifying for DIC. Okay, so what do you do with lab values that aren't repeated? So because subjects do have to have MODS, as we talked about, at the time of consent and at the time of sample 1, what do you do when that lab value isn't repeated so you don't know if they still have MODS or not? So we say that clinical labs documenting organ dysfunction are essentially good for 24 hours. So that's the time of the lab plus 24 hours. Unless there's a repeat clinical lab that documents the resolution of organ dysfunction in the meantime. So let's say you have an intubated patient, so we know that they have respiratory dysfunction because they're intubated, and at 4 a.m. they had a PTT of 75. But you're coming in you weren't able to enroll them on, February 1st. So you come in now the next day, see if parents are there and you're kind of rescreening them to make sure that they still qualify. Well, if you're coming in now the following day on the 2nd at like 8 a.m., if they did not have another PTT done that morning that shows an ongoing dysfunction, then you're essentially outside of that 24-hour window, and we would no longer count that PTT from the prior day to qualify. They'd have to meet some other kind of organ system criteria. So that's your like 24-hour window for qualifying. For GI dysfunction, they would have to have a GI bleed and one of the following that's believed to be a result of the GI bleed. So a drop of hemoglobin of at least 2 over a 24-hour period, or blood transfusion, or hypotension with blood pressure less than 5th percentile for age, or GI surgery. We do include kind of this hypotension blood pressure tool. Sometimes also people get confused. This tool is not to be used for determining cardiovascular dysfunction. This tool here is only used in the setting of when you're evaluating for GI dysfunction and they have to have a GI bleed and you're trying to see if they meet that hypotension for less than 5th percentile for age. So we've got male versus female and then age in years, and then you could determine if they meet that criteria. If they have GI surgery in the setting of this GI bleed and evaluating for GI dysfunction, we'll follow the same logic as the cardiac arrest, meaning that the surgery only counts on the calendar day of surgery. I would say in this sort of scenario, it's going to be really hard to truly capture these kids because of the whole post-op, everybody's busy and trying to get parents. But just so that you're aware of kind of that restriction.
And that's surgery because of the GI bleed.
That's correct.
Correct. Okay.
Correct. To meet renal dysfunction, they'd have to have at least one of the following: a BUN of greater than or equal to 100, or creat of greater than or equal to 2 without pre-existing renal disease, or new dialysis or hemofiltration. subjects that are on chronic dialysis cannot have acute renal dysfunction through criteria. So if they're on any kind of dialysis at baseline, you can just go ahead and not even screen for renal dysfunction. For hepatic dysfunction, it would just be a total bili of greater than 3. Similarly, if they have a bili of greater than 3 at baseline, they cannot have acute hepatic dysfunction. To meet neurological dysfunction, it would be fixed and dilated pupils or GCS of less than 5 in the absence of neuromuscular blockade. They can be on sedation. I'll talk about that more in a minute. And I'm sure this is like part of charting within your EMR, but this is just the GCS tool. So to back up to the fixed and dilated pupils, they do both pupils have to be fixed and dilated, which would be like greater than 3 millimeters. If it's just one pupil that's fixed and dilated, they would not meet that criteria. And then again, for the GCS, even if they're on sedation, that GCS of 5, we will still count that for neurodysfunction. That would be, I know for some of like for PRISM and PWOD scoring, we typically, if they're on sedation, we won't score them for those tools. But GCS less than 5 is really quite low. And so even sedation alone should not make their GCS that low. So if it's less than 5, even with sedation, we still would consider that. But if they're on a neuromuscular blockade, we cannot evaluate at all. And I would also say whether that's a continuous neuromuscular blockade or within, if you're evaluating the GCS within 2 hours of like a single dose of a neuroblockade. So, you know, if they got rocuronium at time of intubation and then they documented a GCS like an hour later, don't count that one. It would need to be at least a couple hours out from when that dose was given.
The fixed and dilated pupils, but one of the exclusion criteria is ongoing evaluation for brain death, correct? So
that's correct.
So that probably would not be one of the least common dysfunctions.
It would probably, yeah, it would probably be less common. Yeah. It does happen, I would say maybe less so because these are also the same criteria. These are criteria that we use not only for inclusion in the study, but we also, part of the documentation for like the data collection that you'll be doing is also indicating on a daily basis which organ systems they meet. So while it might be less likely that they would meet study criteria for fixed and dilated pupils, this is something that might come up a week into data collection if they're, you know, withdrawing care or something like that further into the study. This is something that you would see. All right, so for consent, so MODS, as we've talked about, must be present at the time of consent and first blood sample. We already talked about it's possible they might consent and would not have any study blood draws completed, just if the MODS resolved. But as a reminder, that is just for the first sample that they have to have MODS. For all of the other samples that you collect, they do not have to have MODS at the time of those samples. They only need to have had at least one organ dysfunction within the 48 hours prior to sample collection. So if you're going in to collect a blood sample and the patient is extubated and they have no other dysfunctions, as long as that extubation occurred in the last 48 hours, you can still sample them. But if we're outside of that 48-hour window, then we would say that they're done with their involvement in the study. And you'll see that that's pretty similar for data collection too, is kind of when we stop that. So just as a reminder, the consent forms are set up with an induction consent form and then a site-specific addendum. The induction has kind of the main body language for consent, and then the addendum has your locally approved language. I believe you guys will have a separate assent form that your IRB asked for. Consent is not complete until both are signed. You might see in any emails or things, there are some sites that have exceptions to this. So just don't be thrown off by that. Some of our California sites, they did not agree to use this style. So we had to create them a separate, like, single consent form. So we do have an eligibility form. As I mentioned, we have a paper CRF for you to use. You don't have to use the paper CRF. You can collect data directly into REDCap. But this eligibility form is like the one piece of paper that we do require you to have, like in paper format, and keep with your consent form. It must be signed by the PI. So if the PI is the person that's screening and assessing eligibility, the PI signature alone is fine. But if it's the coordinator that's filling it out and doing the screening, then you do at some point need to go back and get the PI signature. It does not, we don't have like a strict timeline. It's not like it has to be done in 24 hours or 48 hours, but we just do want a signature at some point. Just helps us to document, you know, oversight and that kind of thing. So at the time of consent, you need to have your signed induction consent form, addendum consent form, any additional institutionally required forms, and that signed eligibility form. And then the PRU worksheet, as long as it's documented in REDCap is fine. I kind of list that on there because it's helpful for people sometimes to work on that in person or like at the time. All right, so sample collections, we're only collecting through previously placed catheters or at the time of a previously scheduled phlebotomy. We cannot use heel stick and finger stick samples. It has to do with the LPS simulation that we're doing. We've run tests on this and it doesn't work. It needs to be from like a free-flowing sort of line. We collect samples twice weekly until they have had a resolution of all organ dysfunction for 48 hours. They've reached study day 28. They've been discharged from the ICU. They've reached our maximum blood draw limit, or they have passed away or withdrawn from the study. So when we're back, I'm going to back up here. So for that resolution of all dysfunction for 48 hours, so we run into, again, some scenarios where we're not sure how to determine that. So if lab values aren't repeated. So we typically sample after the first two samples. We try to fall in line to a Monday, Thursday sampling scheme. It helps to kind of keep it consistent for everybody. It avoids weekend sampling, that sort of thing. I will say we have like a plus minus 1 day leeway, especially because a lot of holidays fall on a Monday. It's fine to get it the next day. So it's already built in. It's not a deviation. You don't have to ask for permission. You have that flexibility. So let's say your patient, so a creat of greater than 2 qualifies for renal dysfunction. So let's say renal dysfunction is the only thing that they have left in terms of organ system dysfunction. So you come in on Monday, they're due for a blood sample. At 4 a.m., they had a lab that was done that showed that they still have a creat of greater than or equal to 2. So you're going to go ahead and sample them. Well, let's say you come back on Thursday then to get the next sample, and they have not had any creatinines done in the last few days. Well, you wouldn't sample them because there's no evidence from the past 48 hours to verify that they have any organ dysfunction. We do say in these scenarios, screen for 1 or 2 more days, just because sometimes those organ dysfunctions come back. So like, let's say you come in on Friday then, and you see, oh, they had a creatinine done of, now it's 1.6. Okay, they clearly have a resolution of their organ dysfunction. We're going to stop studying, and they're kind of done with data collection and that sort of thing. So let's say though, when you came in on Thursday, they had a creat done the day before on Wednesday. Well, then you could go ahead and sample them on Thursday because there was clear evidence within the past 48 hours that they still had ongoing renal dysfunction. So the most confusing one then is VEX. So same kind of going back to the initial scenario, you sample them on Monday with a creat of 2.1. When you come back on Thursday, you don't sample because, as we talked about before, there's no evidence of ongoing renal dysfunction. This is why we say go ahead and screen them, just like kind of watch them for 1 to 2 more days, because sometimes those organs come back. So like, let's say on Friday then, you know, because they've spaced out their chemistries that they're drawing. And on Friday, they have a creat of 2.1. Then we would say, go ahead and pick up sampling again. Keep sampling. And the reason for this is because there was, based on the documentation that we have, there was no clear resolution of organ dysfunction, because our creat again on Friday still shows ongoing renal dysfunction without some sort of resolution in the interim. So it can get a little bit confusing. We try to have these in our MOO. There's like a whole section of like all these different scenarios and timings and that sort of thing. So if you have any questions about whether to keep sampling, stop sampling, you're also just always free to reach out and ask. But we tried to kind of put up some of the most common scenarios that might come up to give whatever clarity we could. Any question about that? Okay. All right, so what our sample collections look like. So these are kind of the little bedside kits with the tubes in them ready to go. So you'll draw 1 ml in a Tempus tube. That needs to shake it vigorously for 15 to 20 seconds immediately after collection. And then we have a purple tap where you'll put 1 ml. You'll centrifuge that at 1000 G for 5 minutes, pipette the supernatant into 200 microliter aliquot. And we do want you to save the pellet for DNA. So you don't have to, and I'll back up for just a minute to say, we do have a video that I will send you the link for that goes over sample collection and actually like is a little bit more hands-on. And I think Mark said he also might come up and visit you guys to do some hands-on stuff. Just so I'm just going through kind of, and we have a whole lab like SOP too that you can follow, but I just wanted to give you kind of an introduction to this. So, all right, so retaining that pellet for DNA from the purple top, you don't have to move that pellet. So in that purple top, you know, you're gonna centrifuge it and pull off the supernatant into other tubes, but you can just go ahead and freeze that purple top with the pellet in there and save that for us. And we've got like labels and stuff that we'll send you. So the purple top, you only collect at samples 1 and potentially 2. So you will always collect the purple top for sample 1. You will only collect the purple top at sample 2 if the white blood cell count at the time of sample 1 was less than 5,000. It has to do with the amount of like DNA and things that we're able to get off of that. I'll explain, you'll be collecting a white blood cell count with differential at each of our study sampling points as well. Oh, right here, I have it here. So you collect the CBC with differential. If it wasn't already done by the clinical team within the 6 hours, within 6 hours of study sample, and that could be the 6 hours before or the 6 hours after the study sample. So if you know that they're planning to get one in a couple of hours, you don't need to order another one. But if they didn't do one and they don't plan to, we are asking that you order a CBC with diff for research purposes. So you'll need to make sure that you have like a reverse billing in place for any CBCs that you need to order so that they're not charged to the patient. And we do reimburse those. We reimburse $10 per CBC that you have to order for the study. You'll store all the samples at -80 degrees Celsius until shipping to us. The green top tube is 1 ml. This one, it does need to be processed within an hour of collection. If you don't process it right away, you do need to put it like on ice or in the fridge. So this is what we're using for the LPS stimulation to look at that TNF alpha production so that we can determine if they have immunoparalysis or not. Ideally, we like this to be performed in a culture hood, but if you don't have one, then it's fine to perform it as cleanly as possible. So for this process, you sterilely pipette 50 microliters of whole blood from that green top tube into each of 2 LPS tubes, which we'll send to you. So these LPS tubes, we will send them to you every 2 months. They get stored in your fridge, and it's got this media in it that does this simulation process. So you put 50 microliters into each of 2 LPS tubes, and then you incubate that at 37 degrees Celsius for 4 hours. And then after that 4-hour period, you pull those out of the incubator, and then you centrifuge those each at 1000 G for 5 minutes, and then pull off the supernatant into 100 microliter aliquot. So after you, I think my computer is dying, even though I thought I had it plugged in. My apologies. 1 second. Not sure why this is, oh shoot, it's gonna make me go back through. So sorry for that. Okay, so when you took that that green top tube and you put some blood into the LPS tube, it really only takes a few minutes before you then put that in the incubator. So you go right back then to that green top tube, and you're going to process the rest of the blood that was in that tube that you collected. So the rest of that blood you're going to centrifuge at 1000 G for 5 minutes, and then you'll pipette the supernatant from that into 200 microliter aliquots, and we'll label those as, you know, green plasma, 1, 2, etc. Similarly, these are going to be stored at minus 80 degrees Celsius until shipment. Going back to that LPS, so that 4-hour incubation, the 4 hours, that 4-hour time frame is really vital. We have done testing, and it's not, there's not a way to calculate, you know, if it was 5 hours, it's not like we can just take that TNF alpha value and like adjust it for the duration. The labs don't work like that. So that 4-hour incubation is really specific. For any samples that deviate from that greater than 10 minutes, we cannot use those. We do have to throw them away. So just keep that in mind. The precision of that timing is really important. All right, so as I mentioned, we will send labels to you. So they are pre-printed per subject. So one Ziploc bag will have all the labels that you need for one subject. And since you guys are participating in AMPLE, we do send some AMPLE labels as well. So there's like a second baggie that's like kind of stapled. So we have the Paradigm and then the AMPLE ones together per subject. Just so that as you're reading the labels themselves, all those numbers, the first set of numbers is your site number, the second set of numbers is your subject ID, and then the last set is the sample number. So for example, our site at Nationwide is 760, our first subject is 001, and then sample 1 is last. We have some eligibility forms to fill out at the time of each blood sample, just to make sure that they still meet criteria. So for the first sample, that eligibility form looks different than samples 2 through 8, because for the first sample, they have to have MODS, and for samples 2 through 8, they only have to have had 1 organ dysfunction in the past 48 hours. So those do need filled out at the time of each sample. As a reminder to double check eligibility for the first blood sample at the time of collection. We have had instances where, you know, a site is screening at 6 a.m., they get consent, they go get their kit, and they come back to the bedside, and things change. So we've had times where in that 1 hour window, the epi has suddenly come off, and now they only have single organ dysfunction. So just make sure that you're filling these out truly in real time, like when you go to the bedside, to make sure that they still meet criteria. I will say other times you've done the best that you can to assess ongoing eligibility based on the documentation and information available to you. And then sometimes, you know, let's say the nurse was delayed in her charting of one organ dysfunction or another, and you might not realize until after the fact that they had some resolution. It will still be considered like a protocol deviation, but it's obviously some of those are outside of your control. So just do the best that you can. This is what our sample collections look like. There's a large Ziploc bag with kind of an outer little pocket there. You'll receive, there are two kinds of kits. We have sample 1 and 2 kits, and then sample 3 through 8 kits. So that the inner large Ziploc part has your Eppendorf tubes that you use to put like all of your supernatants and things in, and then a sample shipping roll, which I'll show you pictures of in a minute. And then the outer pouch that's pictured here, it has a mini collection bag as well as your collection forms, both the eligibility form and the sample collection forms themselves. Make sure you save everything. Save your Ziploc bags and your shipping rolls, because these are things that you'll use when you ship the frozen samples back to us. All right, so these mini bags are a way for you to just be able to grab those pieces of the kit and go to the bedside. It has your Tempus tube, your green tap tube, and your purple tap tube, as well as like a quick reference card on the volume. So the reasons that we have samples 1 and 2 kits and then samples 3 through 8 kits are because the 3 through 8 kits don't have the purple tap tube. For the CBCs, use your institution's own collection tubes for these. Make sure that you have reverse billing set up for those. And then this is what our sample collection forms look like that come in the kit. You'll see here highlighted that for sample 1, you're going to assess pubertal development. And this is only, it's like a one-time assessment. So you'll go to the bedside and you'll have a chat with the nurse about this. So Tanner stage 1 would be pre-pubertal. Tanner stage greater than 1 would be peri or post-pubertal. So basically you can go to the bedside and ask the nurse if they have any kind of breast bud development, pubic hair, underarm hair. That is all going to be peri or post-pubertal. If they have none of that, no signs of puberty whatsoever, then they'll be marked as a Tanner stage 1. The reason that we have this on the sample collection form for you to go to the bedside and chat with the nurse about is because this is not something that's documented in the medical record. So you will not be able to find this if you're trying to do it retrospectively. So just make sure that you're filling these out. And then there is a spot in the CRF to document as well. On the back of our sample collection forms is just kind of some handy information, which I will go over in future slides, but basically sample volumes, guidelines if you need to reduce sample volume, and then like kind of a schedule of sample collection. So this is that reduced sample volume. We do provide this for, because we don't have an exclusion for our tiny babies. As long as they're at least 40 weeks gestational age, even if their size is small, there is no exclusion. But particularly for these kids, as well as even the kind of smaller range kids that are in multiple research studies, or their hemoglobin is low, and so the team is a little bit worried about extra blood draws and that sort of thing, you can use this reduced volume sampling scheme that we've provided here. This table, the big one with the kilograms on the left with the 3, 4, and 5, this is not exact. You will still use the you need to track based on your patient weight. 3 mLs per kilo of blood for the study is the maximum that you can draw. These are just to give you an idea of what that might look like based on your patient size. These standard sampling volumes don't include the purple tap at time point 2 since most patients don't use it, but be sure to just track blood draws carefully per patient. So this is our sample collection calendar. So as I said, starting with sample 3, we fall into like a Monday, Thursday sampling scheme. So that should be pretty easy to follow and adjust as needed. Your second sample, that timing is really all dependent upon when you got the first sample. So like in the top row here, if you got the first sample on Monday, ideally we would love the second sample on Thursday, but your okay kind of lenient day would be Wednesday. Whereas with the 3 and beyond samples, you have that plus minus 1 day, but for the second one, it's not quite a full plus or minus 1 day. That's why we give an ideal day and then kind of the like, we'll accept it on this day sort of thing, if that's not possible. The one that tends to be the biggest problem for people is if you get your first sample on a Thursday, both your okay day and your ideal day fall on the weekend. So if you don't have staff available on the weekend, then we would recommend getting the second sample on Friday. So it really, you'd be sampling basically Thursday, Friday, skipping the weekend, and then getting the third sample on Monday. So that would be sort of the next option for that. But as I said, ideally we would like it on Saturday or Sunday based on this. This is that other table that's on the back of your sample collection forms if you need a reference for that. You'll store all of those samples at -80 degrees Celsius and then ship to us quarterly. We do reach out to all sites each quarter to arrange a shipment date. Usually I'll send you like 3 weeks worth of dates and tell you to give me like your first 2 choices of shipment dates, and then I'll confirm. These are via FedEx overnight priority. You ship them on dry ice, the whole deal. So just keep that in the back of your mind. If your freezer is getting full and you need to ship to us before the next quarterly shipment, that's fine. Just reach out to us to discuss, and we're happy to arrange that. When you do ship to us, these are those absorbent shipping rolls that I mentioned come in the large Ziploc bags for your kits. So each absorbent shipping roll should contain the frozen samples from one subject from one time point. Try not to mix and match. This helps us when we're receiving these samples to be able to accession them appropriately. And then once you've got kind of all of your absorbent shipping rolls with your frozen samples, you'll use, again, those Ziploc bags to put those in. Just, again, make sure that you are putting only one subject in a bag. And it might take a couple of different bags for that. You know, if the subject has 8 samples, it's going to take a couple of different bags to fit those. Just don't put like collection 1 from one subject and then collection 1 from a separate subject in the same bag. With your shipment boxes, you'll fill them 1/3 with dry ice and then put your frozen samples in. And actually, we're asking to put maybe additional dry ice on top. We've had some sites that have sent us samples and they've really not included enough dry ice. And then they're thawed when they get to us. And then at that point, we just have to pitch them. So just make sure you have tons of dry ice in there. We do send you all the labels that you need. We'll send you a dry ice label, which needs to go on the outside. Make sure you don't write on the white diamond, like inside the white diamond on that label. We'll send you a biohazard sticker to put on there, as well as your UN 3373 category B sticker. Make sure that you place a copy of all of your sample collection forms before you close the lid on your box. And then we will create you a FedEx label and send that to you. All right, so kind of moving into a little bit of data collection. I'm trying to look at my time here. Oh my gosh, I only have 5 minutes, so I'll try to be quick. But essentially, we have a screening report that we use. If you do not have anything like this and would like some help setting that up, we have some information available that we can help set this up for you. Basically, it's like a really quick first pass at screening patients that we have found just really reduces the time it takes to screen. This is kind of just an example of what our REDCap looks like. Most of your data is going to be in this daily data form that's repeatable. Subject IDs are auto-generated in REDCap. They do correspond with the pre-printed sample labels, so just make sure that you're keeping those numbers together, generating REDCap IDs in the same order that you're assigning your kits. Some definitions for data. MODS onset time, as we talked about, is the start of at least 2 acute organ dysfunctions. Study day. So study day 1 is the full calendar day of MODS onset. So even if MODS didn't start until 10 p.m., we're still going to collect any available data for that full study day. Study day 2 then is the calendar day following MODS onset, and so on and so forth. We'll only consider a subject discharged from the ICU if they stayed out of the ICU for at least 24 hours. If they're readmitted back to the ICU within 24 hours, you'll consider this a continuation of the initial ICU admission. In our MOO, we do have a whole section on data collection, so you can get more information there, but these are some of kind of the bigger highlights. I'm going to bypass this. Just know that we have some different etiology buckets for MODS due to trauma, sepsis, bypass, and other. So just know that that might be, if you have any questions about which bucket they're in, reach out to us and we can help figure that out. We always recommend trying to do data collection in real time. If that's not possible, at the very, very least, if you could please fill out these forms, the eligibility, the approved criteria, and the sample collection forms. That is very helpful for us from a tracking standpoint. Again, I'm going to bypass this because it is available in the MOO. I will send these slides too so you can look at them. I'm trying to be respectful of Amanda's time for ample as well. We do have some document uploads, microbiology, virology reports, and that sort of thing. Again, we already have the instructions there available to you. So the MAR, I know that I've talked with Ryan about this a little bit, but one of our aims is to look at treatment-related factors for immunoparalysis. And a big part of our treatment to our patients is the medications that we give them. Sounds like you guys are already, Ryan's already aware of this and kind of working on the MAR extraction. I think you have the code. And then once we'll work with you outside of this meeting to kind of finalize that process. But then just know that we do have a spot in REDCap where you can actually upload that MAR data so that we're not sending it via email. We are looking at nosocomial infections. So if you have a patient that does have a nosocomial infection, these do need to be adjudicated and confirmed by your PI. You'll see in the MOO and in the CRF, there is a form that you can take to your PI to go through that information with them so that they can confirm. We do screening in REDCap. It is a separate REDCap project called Paradigm Screening. So just make sure that that information gets put in on a monthly basis. This is just to be aware that sometimes when we're extracting data from the EMR, sometimes we run across artifact data. So just to be aware to look out for things that seem on maybe the more extreme end. If a patient was either receiving chest physiotherapy or being patted by the parent, and there's maybe a spike in the heart rate because of that, sometimes it's documented in the EMR because as a bedside nurse, we're not always great about verifying our data. So just because it's documented does not always mean that it's accurate. And from a research standpoint, we do want to do our best to be only capturing the data that appears to be accurate. Now, just because something's outside of the realm of normal also doesn't mean that it's artifact, but just to be aware of what might be true data versus artifact data. We do see this a lot with temperature probes. They're inserted and then all of a sudden it comes out. So you might have a temperature documented as 37 degrees Celsius, 36.5 degrees Celsius, and then suddenly it's 28 degrees Celsius. And then it's right back to 37 degrees Celsius. Well, that 28 was probably because that probe came out and needed to be reinserted, that sort of thing. So that's what we're getting at. So just be aware, if you have questions about this, let me know. These are often things that I pick out when we do data queries. So I might have questions for you on this, like, well, is this real? Could you maybe check to see if this was artifact or something like that? Same goes for hemolyzed labs. If a lab was hemolyzed in general, we're not going to want to include that. But if the clinical, in those cases, typically the clinical team will reorder a lab. So then you would use the reorder to document. Queries, again, I'm going to kind of bypass this. Just know that we do these quarterly, but I'll give you instructions and work with you when it's time to do this. Regulatory documents, make sure that you have a delegation log to fill out for your site and a training checklist for study staff member. These are available in SharePoint, and I can send them to you as well. You can email those either to the Paradigm Study email address or to me directly. But we do have to have these on file before your site can start enrolling. All of your other source documents you can maintain at your site as you do your other studies. SharePoint, which I think that you guys all have access to, we do house all of our current study documents. So this is not an essential documents binder because we don't have like archived versions. It's just the most recent study documents. But it does contain consent documents as well. So please try your best to print consents directly from SharePoint. Since we don't have like a centralized IRB location for you to get that, we have had issues of people using outdated consent forms and then running into issues with that. So if you print them directly from SharePoint, then you know that you have the most up-to-date documents. If you have any issues accessing SharePoint, reach out to me and I can help you with that. This is just the payment structure. Just know you do not have to invoice us. I generate, we have like an auto payment structure. So I generate these and I'll send them to you to review before we submit them and get you paid. We do pay quarterly, just based on anybody that's been enrolled and had completed data in the last quarter. We do have monthly coordinator calls and quarterly PI calls. And I do try to send out like monthly emails with study updates and education and stuff like that. You guys aren't doing Precise, is that correct?
No, we're not part of the.
Okay, so I'm going to bypass the Precise stuff. There are some slides on co-enrolling with Tropics. Similarly, I'm just going to bypass that because again, it's in the MOO. We can discuss once you get going with both studies, we can talk about kind of specifics related to that. Sorry, so I know that I really did kind of breeze by a few things there just for the sake of time, because it's also a lot of information, so that I know it takes time to absorb, and so I think we can go back in and kind of figure out the nitty-gritty as you guys start screening, because I think it makes more sense once you have kind of real patients and real information to work with. But any kind of like overarching questions right now that we haven't answered? Okay.
Good from my end. Thank you.
Okay, cool. Amanda, do you want to take over and go over Ample?
Yeah, for sure. So I will share my screen. Let's see. Okay, can you see my slides?
Yeah.
Okay, great. So I know that was a lot of information and we'll try to transition and I'll be cognizant of time as well. But thanks, Josie, that was really great for the paradigm slides. So luckily, Ample leverages most of the paradigm infrastructure. So because infection is so common in children with MODS, the goal of our study is to leverage paradigm and to identify optimal antibiotic dosing strategies for this population. We're going to use samples and clinical data from paradigm subjects to characterize the variability of concentrations for the most commonly used antibiotics in pediatric MODS. So while it's the same reliance agreement, it's still through Nationwide and Paradigm. The PIs of the study are actually Doctors Kevin Downs and Mark Sheets, and I think Mark, you just joined us. So welcome.
Hello.
Okay, so I'll just get right into it if I can get my slides. So to go through some definitions first, the qualifying antibiotics that we are interested in include vancomycin, piptazo, cefepime, meropenem, ceftriaxone, ampicillin, and amsulbactam. Consent and assent are embedded in the Paradigm consent. So it was required that the patient's families consent, assent into Paradigm, as well as Ample to be eligible for Ample. Eligibility is defined based on when the subject meets all inclusion criteria, which I'll go over in a second. That makes them eligible for ample sampling. They can become eligible for ample sampling at any time during Paradigm, while more often than not, it's going to be at the time of consent. And then ample day 1, we call the first day of PK sampling, which again, because this eligibility is so variable, it can be at any time. So inclusion criteria, they have to be an active participant in Paradigm. So I know, Josie, you were going over that situation earlier in your presentation about if they got consent, but then weren't able to get sample 1 because of they fell out of mods. And in that case, they would no longer be eligible for Ample. They have to be an active participant in Paradigm. They have to be consented to Ample, like I said, and they have to be receiving 1 or more of our qualifying antibiotics via IV. Again, more often than not, they'll already be on 1 of our qualifying antibiotics. If they are not on 1 of our qualifying antibiotics, then we would just watch them through the duration of Paradigm. And if they were to start 1, you can start ample sampling. Like I said, written informed consent.
I'm gonna jump in real quick. So
Yeah.
This, Brian, is a situation where for ample, you would in theory consent them for ample before they officially qualify for ample. Qualify meaning like they're on 1 of the antibiotics. So that one is a little bit different because regardless of whether they're on the antibiotic, they're going to either agree or not agree to ample. And then you kind of determine later, potentially, if they're started later on 1 of the qualifying antibiotics, and then you'd start sampling. So I just wanted to make that connection to kind of the question earlier.
No, it's when the consent is done, prepared
Right.
then. Yeah.
Thank you, Josie. So written informed consent is obtained at the same exact time. Ample is an optional portion embedded in the consent form. So the patients and families, they can say no to Ample and still participate in Paradigm. However, they cannot say no to Paradigm and still continue procedures in Ample. So Paradigm is required for participation in Ample. And then, like I said, once they're consented, the procedures may begin at any point during Paradigm should they begin a course of 1 of our qualifying antibiotics. So there's just a little diagram explaining exactly what we just said. Just more for fun as we just went over it. So yeah, so if they were not immediately eligible, you would check them daily and screen them for their 1 of our antibiotics. Should they begin, you can begin sampling. But if they end their time in Paradigm and they never started 1 of our antibiotics, that's okay. They just never started Ample. So this is our approach to blood and urine sampling. So Ample day 1, like I said, is the first day that a patient is to undergo PK sampling. The goal is to start PK sampling as soon as possible following their eligibility, but we have some flexibility. So there's the 3 calendar day eligibility window from the time of Ample eligibility. There's a little diagram showing that as well. So when you begin, we are asking for 5 time points a day of PK samples for 3 consecutive days. And we call those days Ample days 1 through 3. And then urine sampling, we want to get urine samples on those same 3 days and then again on days 5 and 7. So if a patient, you start sampling, PK sampling on 1 and 2, and then they get off their antibiotics on day 3, you would not sample for Ample day 3 PK samples, but you would continue urine sampling. So urine sampling you can continue regardless of their status in Paradigm or their antibiotics. As long as they remain in the ICU, we'll still get those urine samples. So this is the blood sample timing that we have for the PK samples based on their dosing interval. So this table is super flexible. It's really hard to get these within the allotted windows, especially when the patients are moving around, they're going to the OR, they have appointments, and sometimes they're just really busy. So they're very flexible, but we want to target these windows as best we can. I have a resource that's also found in the Paradigm SharePoint called the Ample PK Calculator, and it's a little R code that one of our colleagues made. So you can actually input the dosing time and it'll output all of the target windows for you. So if a patient is on more than one of our qualifying antibiotics, we want to focus our PK strategy around the one that will be most feasible to collect all 5 samples. So, if you have a Q24 happening, ceftriaxone at midnight, but there's a cefepime dose that's being given at 8 a.m. and it's easier for your team to be able to get all 5 samples within the business hours, you can totally go for the cefepime over the ceftriaxone.
Amanda, can you just say that one more time? Just because, a lot of patients are going to be on Vanc and cefepime or whatever. And so you're saying if they're on more than one, focus on the one that most feasible to collect the most samples. Okay.
Yeah. So it's really up to you on your site. We don't have what I'm saying is that we don't have a preference over which dose that you use if they're on more than one antibiotic, what other qualifying antibiotics. And it's, some sites have the ability to do overnight sampling. They're working with their nurses. That's something that we're doing here at CHOP, so it's not as big of a deal. But if you don't have coverage after those hours, it might be easier for you to be able to choose a window where it's going to be easy to get all of those PK samples within your business hours.
Okay. So you don't have a preference between a Q6 Vanc or a Q24 ceftriaxone? Okay.
Yeah. I mean, if we're getting technical, there's a lot of Vanc. So we're going to have an overload of vancomycin. But again,
Sure.
if it's most feasible for you to get vancomycin, then yeah. But as we go along down the line, obviously we just started, so we don't have much of a preference right now. But towards the end of the study, if we have an overload of vancomycin and we have like 0 ceftriaxone or not as much ceftriaxone, we might start to skew it in favor of that. But for now, it's whatever is most feasible for you.
All right. Thank you.
Definitely agree. For now, full speed ahead on Vanc. Patient enrollment is the key right now.
Right.
Have you met ICU doctors? We're nothing full. We're all about full speed Vanc. That's what we do.
I love it.
So from us, you will get this insulated shipping container. It'll contain the kits that you'll need for PK sampling. So there's the PK sampling kits and the urine collection kits. And we have these same little absorbent sleeves that Josie mentioned in her presentation. We'll use those for the urine collection kits. So you can stick all the urine samples from one subject in those and ship them over with that. So hold on to all of these materials that we give you. Okay, so starting off, what happens after a subject is eligible? So there's 2 kind of sets of worksheets for Ample. So there's the subject worksheet pack, and that's kind of all of your real-time documents. And then there's a couple extra data collection pieces that are embedded within the Paradigm CRF. So you would print off the Ample subject worksheet pack, and the first thing you would see is the Ample eligibility checklist. And you would fill out their eligibility. And then there is an Ample subject schedule. And this is just outlining the days. Honestly, this form is kind of optional to help you organize yourself as you go through PK and urine sampling. And it just shows exactly what this table is showing. Just you would input the days that day 1, day 2 is 3, and you can go back to it, add comments like I wasn't able to get PK 1, 2, 3 or 1, or wasn't able to get a urine sample and things like that. So after that, you would get your PK sampling kits. These are what the kits look like. So the PK sampling kits will contain 5 silver VAMS meter bags, and that'll be enough for 1 day of PK sampling. On the bag, you can circle which Ample day it is and your subject ID. Inside each of these foil packs is a purple cartridge with 2 tips. And there's also some desiccant in there, and do not remove the desiccant because you'll put the purple cartridge right back in the foil pack and it'll remain in there to dry. And these are really handy. They're only 20 microliters each tip. So you only really need a couple drops of blood. Okay, So now when you're preparing to go get a PK sample, you'll take your subject worksheet pack with your kit, and you'll look at there's going to be a set of 3 worksheets. The first is the ample PK blood sampling eligibility worksheet. This is a little different from the first eligibility worksheet. The first one, like I said, there's a 3 calendar day window between when you can get your samples after eligibility. So there's a possibility you might be filling out both of these eligibility forms on the same day, but it's just to confirm before you go to the bedside that this patient is still eligible. They are one of our qualifying antibiotics and so forth. The next sheet is also kind of a preparation sheet. It's not required, but it's the ample PK blood sampling RC prep sheet. And that shows that table that I showed you earlier with all of the dosing interval times. So you can kind of circle which antibiotics that the patient is on and figure out what your schedule is going to be for that day. And then the last sheet, which is the most important sheet, which I have a picture of on the next slide, is the goal sample or the ample PK blood sampling collection log. Sorry, there's a lot of words going on. And then you want to fill out the goal times. And after you use that PK calculator to kind of set yourself up, you can fill out there. So this is the collection log. So you'll notice this first table up here. And this is where you would put the doses for that day. So you're not only putting the dose for the drug that you're sampling around, you would put all the doses that day prior to PK1 through PK sampling. So if they had a Vanc dose at 2 a.m. and then they had another one at 8 a.m. and then you started sampling at like 9, we only want to know the 8 a.m. dose in this table. There's another space where we put all of the doses over the whole 7 days, but for the purpose of this sheet, we want the doses that are really close to the PK sampling times. And also, these are really important for our modeling, so it's really beneficial to have a chat with the bedside nurses and make sure that you're getting as close to accurate as you can start and stop times. I've noticed recently going through the data that a lot of sites are relying on the MAR when they go back to their seats and they're looking in the chart, and they notice that the nurses are not actually inputting their start and stop times. So this is very much a real-time document. If you are able to, and it's not an overnight dose, and you can kind of chat with the bedside nurse, I would just ask them to confirm, hey, when did this dose stop? Or when did it start? And then you would see the column here, that's where you would put your goal ranges. And then the most important column is the actual sample date time column. So like I said, the goals are targets, but they're super, super flexible. And it's really the most important to us to know when the sample was actually taken. And that's where you would put that there.
Can I ask, the antibiotic table up top, is that the drug of choice, or is that all of the antibiotics that they've gotten after that sample?
It's for all of them. So yeah, so you would want the first dose of each qualifying antibiotic given prior to PK1, and then the doses through PK sampling. So
Ryan, this table. Oh, I'm sorry.
No, go ahead.
I think it makes sense to, when we go to analyze these samples, we're trying to know what we're looking for, what might be in the blood at that time, like what was actively given during the time when that PK sampling set was done, what was potentially infusing during that time. So that's what this box is for you guys to let us know, okay, this is, we're testing, let's say we're looking at cefepime, or we're looking at cefepime, and so we're going to put, okay, the dose of cefepime that was given, and then all the, PK sampling times around there. But, oh, by the way, they were also given a dose of vancomycin during the time that we were PK sampling, and oh, by the way, they were given something else.
Perfect.
That way we know what we're looking for.
Okay, that's what I want to know. Is it all the study drugs or just the one that we cared about? Okay.
Right. Yeah. So for the goal times, it's based on the one drug that you're targeting. But for that box up there, it's important to know all of them.
Yeah. I agree with what everybody said. So we have a multiplex assay that can look at any of the ample drugs. But for instance, if you have a fluoroquinolone or something like that, you don't have to list that.
Okay, so for PK blood samples, they can be obtained from an existing arterial catheter, venous catheter, capillary puncture, or phlebotomy being performed for clinical reasons. So this is a bit different than what we were saying for Paradigm. So in Paradigm, they do not do capillary punctures, but that is an option for Ample. So I think it's an important thing to mention to the families when you're consenting. There is language in the consent form that says that your child will never be stuck for purposes other than their clinical purposes. So, but that's not true for Ample. And sometimes that kind of deters family. They don't like to participate if they know there's going to be up to 15 capillary punctures for the Ample study. So you can pose this as a question that's totally optional, and the capillary puncture is our last resort anyway. We will almost always go for the arterial line, venous catheter, or phlebotomy. And if they are comfortable with the study, but they're just not comfortable with the capillary punctures, then they can opt out of that, and we'll only sample with existing lines. When drawing from a catheter, we just need a fresh sample. We don't want any waste blood. And we do not want samples that were drawn from the lumen of the existing venous catheter where the qualifying antibiotic is being administered. So that's another conversation with the bedside nurse. If they, for example, don't have an ART line and they have a couple PIVs, we can draw from those PIVs if they're blood drawing, but we would really prefer not to draw from the line that had just been infusing the antibiotic. And a lot of times this has been a little bit of a problem because sometimes the nurses don't know. And I think we are most concerned with the dose of the qualifying antibiotic that was given most recently to the PK sample. So if they know it was given during the last one, we don't want to use that line. But if maybe it was given a couple doses ago, but it wasn't used for this most recent dose, then we would still be okay to use it. Is there a question with that? Because this has come up a couple times.
For multi-lumen central lines, are you okay drawing from another port, essentially?
Yes.
Okay.
And then this isn't also at every site, but it came up again that some sites, when they're doing their clinical lab testing and they're having arterial blood gas ordered, they'll be using a heparinized syringe. We don't want to use the heparinized syringe for Ample PK samples. So if that's the only clinical lab that they're getting, we would just ask that they get their small 0.1 blood out of a normal syringe, not a heparinized one. Okay, so this is the actual process of collecting a PK sample via catheter phlebotomy. So we only need 0.1 mils of blood. We want to record the time on this little foil pack and the same on the PK collection log that the blood was actually drawn from the patient, not necessarily the time that it was loaded onto the tip. You would just take out the purple cartridge and expose the tips. And it's really important to hold the tips down at a 45-degree angle and hold the syringe upward. It has its absorptive properties, and that helps us make sure that the tip doesn't get overloaded, and we keep it to that 20 microliter volume. So you touch the tips to the syringe. You can do the same to the other side, and it's super easy. You just close it back up and put it right back in the foil pack. So these samples need to dry before they are frozen. They can either dry at room temperature for up to 3 hours, or you can put them directly in a 4 degrees Celsius refrigerator and they can dry there, and they can even stay there up to 72 hours. If they're drying room temperature, they have to go somewhere after the 3 hours. They could either go in a -20 or a -80, and they ultimately have to be in the -80 at the end of 72 hours. So there's a lot of flexibility, but the most important thing is that they dry before they're frozen. But we have stability. This is really important for weekend sampling. So sometimes we are leaving some kits at the bedside. I don't know if that's going to be an option for you, but if it is, you can instruct the nurses to put them right in the 4 degrees Celsius refrigerator, and then one of your research team can come pick it up on the Monday, and it'll still be stable, and they can put it right in the -80.
That was my question. How long can it stay in the fridge from your point?
In the fridge, it can stay up to 72 hours.
Up to 72. But
Yep.
before freezing, you'd say 24.
So it's a little confusing. I guess you could say you could put it in the you can put it in the fridge, but then say you don't have immediate access to a -80. You can also put it in a -20. And I think I said 24, but I meant to say 72. So that can say also in a -20 for up to 72 hours. They just have to end up in the -80 at the end of 72 hours.
But as far as drying out in the fridge, do you have a minimum time?
Yeah, probably 3 hours. Same as room temperature.
Same as room temp. Okay.
Yeah, or up to 3, I could say 1 to 3 hours.
Okay. But then can stay up to 72. All right.
Right. So this, I'm sure your nurses all know how to do a healer finger stick, but it's the same process. I'll kind of breeze through these. And you would again just instruct them to try to hold it down at a 45-degree angle to absorb the blood. And it's the same thing. You would pop it right back in the foil pack and then you can let it dry and then freeze. So this is an example of what under versus over sampled looks like. If it's undersampled, you'll be able to know. You can see that the tip is clearly still white, and you can just lower the tip into the blood until it is fully loaded, as the middle picture shows. If it's oversampled, there's really not much you can do about it. The good thing about this is that you have 2 tries since there's 2 chips. We would prefer not to be oversampled, but if it is, you can just write a little note in the comment section and to let us know, because it's a lot harder to see if it's oversampled after it's dried. But the middle picture is what we're looking for. So after you got the PK sample, you just want to place the purple cartridge back in the correct silver bag. They both have barcodes on the tips, cartridge, and silver bag. So just make sure it gets put back in the same one, but otherwise you can kind of ignore the barcode. And then the research team should fill out the actual date, time collected, and the sample site column of the collection log. Again, that's super important for us to know the actual time that it was collected, even if it severely deviates off of the target time. And again, this is just the drying instructions. The urine collection kits, they're also provided by CHOP. Josie mentioned about the labels. So these are the only labels that will come from Nationwide, because the subject IDs are the exact same as Paradigm. So the urine labels will come in the same little pack from Josie from Nationwide. Each of the kit contains a 15 ml conical tube, 3 screw top tubes, 3 snap top tubes, disposable pipettes, and the urine collection worksheets. What kind of centrifuge do you have? Is it able to house a 15 milliliter tube, or do you need it to only be the little 2 ml tubes?
Let me check.
Okay.
We had to get an insert for the Eppendorf. There is a base insert in there, and I'm not sure if it was a 15 conical.
Okay, great. Yeah, so the only reason that the snap top tubes are here is in case you didn't have something that could centrifuge the big 15 milliliter tube. So there's both options there, but basically they're just going to get spun down either in the 15 tube or in the little ones, and then they'll get transferred to the screw top tubes. So either way, it doesn't matter. I just wanted to see what kind of materials you would need.
So okay. So either way, because we would be using the Eppendorf, the snap tubes anyways for Paradigm. So you're okay with spinning down in that?
Yeah.
And then transferring to the screw. Okay, that's easier than probably just for us to do.
So the urine samples can be obtained via urinary cath bag, bedpan, urine cup, cotton balls, any way, just using your approved site protocols. If you're using a cath bag, we would like a fresh collection. And sampling can occur at any time during the ample day. And we just need at least 5 mL of urine. Ultimately, we're gonna have 3 mL total of the centrifuge supernatant. So at least 5 mL is fine. And then we just want to know the volume and the date and time collected on the urine collection worksheet. So this is what I was talking about, the urine processing. If you had the 15 ml tube, you would spin at 400 Gs for 5 minutes. And you would transfer it right into the screw top tubes and you put it right in the -80. And then otherwise you would just transfer from your urine cup or the 15 tube into the small snap top tubes, centrifuge them there, and then transfer into the screw top tubes. and again, go in the -80. There is some flexibility here with processing. If you can't get to processing right away, they can sit in the fridge for 24 hours and then you can process after that. And on the other end, if you don't have immediate access to a -80, after you process, you can put them in a -20 before putting a -80 for up to 24 hours. So now I'll just get into some data collection. I'll kind of breeze through this. So this is one of the last forms in the AMPL subject worksheet pack, and this is the course adjudication log. So we want to know if the antibiotics were given empirically, definitively, and prophylactically, and that's pretty hard to find in the chart. So that's why this is a page that's included in kind of the real-time document pack. So if you can kind of flag down while you're over there getting samples, the physician fellow, and ask them why they were giving the antibiotic to the patient, that would be most ideal. Or if it's easier for you, Ryan, they can ask you if you can look back into the chart and identify whether it was given empirically, prophylactically, or definitively. So Paradigm is already collecting microbiology reports. This is just a tidbit to remind you that when you're putting those documents into the REDCap, to also include the MIC data and the susceptibility data, because we will use that. Okay, these are sheets of data.
Sorry, is that, so we had to design or pull our own data to pull the drug dosing and timing and all of that. Is this part of some of the IT stuff you guys had sent me, or is this something that you want us to type in?
Yeah, so no, this isn't, I think we kind of got to the end of this in Josie's presentation, so we skipped over it, but no, this isn't part of the IT stuff.
Okay.
This is in the Paradigm, in the form called Demographics and Hospital Summary. We are looking for all the positive microbiology and virology reports from 72 hours prior to MODS onset through ICU discharge or 28 days after the last study sample was obtained. And that's just by looking in the chart and kind of uploading de-identified reports of for microbiology and virology. So it's there, you're not manually entering anything, you're just uploading the reports.
All right.
And then this, what I'm pointing out here is that sometimes they just put the top part of these reports, and it's important for AMPL purposes to know the susceptibility data too. At the end of the Paradigm CRF, there's some data collection. We're looking at labs for days 1 through 3, as well as days 1 through 7. So we're looking for hemoglobin, hematocrit, albumin, total protein, creatinine, serostatin, and vancomycin levels, if applicable. The antibiotic log is separate from the PK sampling log. So this is where we're capturing all the details of all the antibiotics given on AMPL's days 1 through 7. And this will also include dosing information and other things that we need there. And then we also are interested in urine output, dialysis, and ECMO. So we would just want to know time on and off circuits if that was applicable, and what their ins and outs were on those days. For the CRRT and ECMO, we have other data points that we were interested in, but didn't know how to accurately get that from sites because it differs so much. So what we came up with is just, again, uploading a de-identified screenshot if they were on CRRT and ECMO. Some of these points are just so different and they look so different across all the sites. So instead of having you dig through your EMR and find them for us, we figured just give us the screenshot and we'll find it from there.
What specifically are you looking for? The fluid balance? You're not looking for pump speed and pressures, because I have ECMO flow sheets, but if you're looking more for CRRT stuff, that's elsewhere.
Yeah, mostly the CRRT stuff. I don't think we're going to really be able to do much with the ECMO flow rates.
Yeah.
But flow rates on the CRRT basically, what your pumping rate is and what rate you're pulling off.
And is that sort of once a day, sort of average type of thing? Because oftentimes, sometimes the fluid rate changes.
The hourly, we'd love to have the hourly and just, sort of treat that like you shouldn't treat your taxes and throw it in a shoebox and send it to us.
like I treat my taxes. I love it. Okay.
Okay, so shipping worksheets, there's a transfer worksheet, just outlines, summarizes all the things that you'll be sending me. And then we have our own ample shipping checklist with instructions on how to pack your shipment. Labels, these should be included in the box of kits that I send you, and then I will coordinate with you to give you a way bill, similar to way that Josie does. I am trying my best to do this on a quarterly basis, but our the antibiotics have stability deadlines, and that has posed a little bit of an issue. So it seems to be a little bit more frequently, more like twice a quarter instead. Most of our drugs have 90-day stability, and that's been great, but meropenem specifically only has 60 days. So I will coordinate well in advance of when we should be shipping, but I'm doing my best to get it on a very consistent quarterly basis. Also, because we're sending these samples to Michigan, they're not getting analyzed here. So I have to get them to CHOP and then turn them around and get them sent to Michigan, which is also causing some issues, but I'll coordinate with you. A sample prep for shipping is super simple. Like I said, these sleeves that are included in the shipment, you would put all of your urine samples in there, all 3 aliquots per day. So if you got all urine on amples day 1 through 7, you would have 15 total in this little bag. PK samples, there's no processing involved, so you just stick them in the bags that they're already in. All we ask is that if you can, just to keep them together. Sample packing is very similar to Paradigm. We want a good amount of dry ice so they don't thaw before they get here. And I just want copies of the collection logs, the urine collection worksheets, the transfer worksheets with the summarizing what samples are in your shipment, and the shipping checklist. And that's all there is to shipping. And then invoicing. Sorry, this is my last slide because I know we're already 10 minutes over. So invoicing, I'm also doing on a quarterly basis. So I will also be sending queries. This is our invoicing outline per samples. So on, for example, today is the last day of quarter 2. So I am this week sending out queries to sites, and they will have around 2 weeks to get their queries back to me. And then after that, I will invoice for subjects that I have samples for. They've shipped their samples and their data is complete. And this is what the invoicing outline looks like. But yeah, that's my last slide. So if you had any questions, I'm happy to answer. I'm sorry, I know we went over a little bit here.
And I know that this was like a ton of information and we went crazy fast. So let this just be kind of a first pass. Definitely take some time with, we do have a separate MOO for Paradigm and for Ample. That's part of the reason I like to do the Go Live trainings, like about a month or, a handful of weeks in advance of when you're actually going to be ready to start screening. That way you have plenty of time to absorb the information, go through the VU, do some practice screening with patients so that you can kind of feel your way around a little bit. So I'm sure that you'll have questions, but yeah, use the MOO as your Bible for both of these studies and our emails to field questions. So thank you guys so much for your time and for staying over a bit for us today. So are you guys going to be at Polisi?
I will be virtually.
Virtually? Okay.
Yeah, it's
okay.
Too hard to get to, and it's like 4 days before my kid's spring break, so I have to work at some time.
Yeah. Well, the reason I asked is that I thought if you guys were there in person, we could bring some supplies that you guys could get some hands-on and take a look at. But I will start working on getting at least Paradigm kit supplies out to you. It's not like a rush, but I thought that way you guys would have some time to kind of look through stuff and feel it out. You can even, sometimes here at Nationwide we'll draw blood on each other and practice sampling ahead of a study. So feel free to use extra kits to do that.
Yeah. Similarly, I have some expired of those Mitra tips, the foil pack. So I will send those to you as well, so you can get some practice on loading those tips.
Yeah, great. I played with those tips in September in Policey.
Right. My food dye blood.
Yes, yeah. So it was a quick learn. So yeah, that would be
Awesome.
helpful. Thank you.
Great. All right. Well, we'll let you guys go now since we're well over time. But thank you again, and yeah, we'll be in touch more soon.
All right, appreciate it. Thank you, guys.
Thank you.
Thanks, everybody.
Bye.
Great having you on board.